Good morning. I consider it a privilege to be replacing Dr. B.N. Chakravarti for this morning talk, and thank you, Dr. Jayakrishnan. The talk that he's asked me to do is what can a clinician do to improve implantation. Obviously, it's a talk that's going to be of interest only to people who do ART. Implantation is supposed to be the last great frontier of reproductive biology. What does that statement mean? The statement means that the reproductive biology, we are overcoming a lot of difficult areas. We can choose the right oocyte now, we can choose the right sperm now, we can choose a lot of other things that we do, but the area of reproductive biology or reproductive medicine that we do not seem to have a handle on is how does the embryo get implanted. We create a great embryo, put it back into the uterine cavity, does not get implanted at all times. So it seems to be a great barrier for improving the results of an ART procedure, and we still do not have an idea as to how to overcome that. And this is a logical way of looking at what that last great frontier means. Suboptimal implantation, where you put an embryo back and the embryo does not get implanted, can be a problem. It can become a problem for the ART unit itself. If you are running a unit and your embryos do not implant very often, less than 20% of your embryos implant, it's a problem for the unit. Okay. So every unit should actually calculate what their implantation rate is. There is something called an implantation rate, where you put in so many embryos and get so many viable pregnancies, and your implantation rate should be in the acceptable range. So every unit should in fact be calculating its own implantation rates. And unfortunately, a majority of units in India today do not calculate their implantation rates, but that's one way of judging whether your unit is doing well or not. And you should also know what the implantation rate for a patient is. You can have a patient where you're putting back the embryos all the time, what you perceive is good embryos, and it's still not getting implanted, and that may be a suboptimal implantation. So it can be a problem for an individual patient, it can be a problem for the ART units itself. What does successful implantation require? Successful implantation requires, first of all, a normal and a functional embryo. Second, the ability to choose the right embryo to put back in. Third, you need a receptive endometrium for the embryo to implant and grow. And you also have to look at your optimal transfer procedure. The embryo may be good, the endometrium may be good, but is your transfer procedure optimal is the next thing that we have to look at. And a synchronized dialogue between the maternal and embryonic tissue is, at the end of the day, most important. So your embryo has to be in good shape, endometrium has to be in good shape, you have to be in good shape to put it back into the right way, and then what happens beyond that is actually not in your hand. It's a synchronized dialogue between the embryo and the endometrium that has to happen normally for you to get an adequate implantation as well. So what exactly is recurrent implantation failure? When you've transferred at least 10 morphologically good embryos into a normal uterus and you still don't get a successful implantation or pregnancy, it's failed implantation or recurrent implantation failure for that particular patient. This number has actually come down over a period of time, because now this was at a time when we were replacing 3 good embryos per transfer. And when 3 good embryos were transferred 3 times and you still didn't get a pregnancy, it was supposed to be implantation failure. But now, worldwide, the number of embryos being replaced is coming down to even a single embryo transfer. So the current definitions in some places are being changed to when we've done 3 successful transfers with good embryos and you still don't get an implantation and a pregnancy. And what are the things that you look at when you don't get an implantation and there's a failed implantation for whatever the reasons are? First of all, you look at optimizing the embryo quality. You've got to be very sure that the embryo is of good quality, and that's the number one concern. And what does the quality of embryo depend on? The quality of the embryo depends on, first of all, the gametes. You cannot start with a poor male gamete or a female gamete and end up with a good embryo. It's not possible. So first your concern should be, is the male gamete adequate or the female gamete adequate? In the male gamete, I think one of the previous speakers this morning was also talking about, when they were talking about IMSI and such, it is DNA fragmentation now that we are concentrating on. You do all of this, and if you have a DNA fragmented sperm, it's not going to implant. And the answer for that is not an IMSI procedure. An IMSI procedure only looks at morphologically normal sperm, and morphologically normal sperm does not equal chromosomally normal sperm. And that's a fundamental thing. You can have situations like a minimal moderate varicocele. You can have a male who's had a transient health problem like a bad viral infection. You can have a male who's exposed to external agents, and the sperm will look normal under a microscope, even under ultramagnification. But however, it may not have normal chromosomes in the head of the sperm, because that is the one area where the DNA gets fragmented very easily out of all human cells is the sperm head. So you have to have the male gamete, you have to look at male gamete more in depth and make sure that the male gamete is okay. You have to look at the female gamete also under a microscope and make sure that that is okay. When we said age makes a difference to the number of eggs that we can get out of a female, it also makes a difference to the quality of eggs that you get. So all of these things become important. Next thing that you look at is the culture conditions. What you do with the gametes in the lab is the next step. And there you look at mainly the media that you use in the laboratory, which we don't sometimes pay much attention to. Media contains a lot of agents which, if it's not properly refrigerated or transported or stored, can give rise to a lot of problems. So one of the things that you look at is the media. And then the next thing that you look at is your entire laboratory conditions. VOCs in the laboratory can bring down your implantation. So VOCs is organic compounds which are present, volatile organic compounds. It can be in the paint, it can be in the construction work, it can be in the things that you use in the hospital for cleaning purposes which contain aldehydes. So laboratory conditions is also very important. The skill of the embryologist will also have to be very good and proven. Okay, you have to have embryologists who are properly trained and not in a hurry, look at the gametes properly and do that. And that is also very important. So in the laboratory, these are the consumables, disposable, laboratory conditions, and the skill of the people that you employ is the things that you have to look at. Stage of the embryo also is important. Cleavage stage embryos and the blastocyst embryos. Blastocyst embryos implant better, and we'll look at it a little later. Embryo manipulations, again, when it comes to that, it becomes important that the manipulation should be done only where it's necessary, when it's necessary, and in the ideal way, that is ICSI and assisted hatching. At the end of the day, it's choosing the right embryo to transfer. You may have 4 embryos, 6 embryos in your laboratory. Which one do you choose to transfer? You've got to choose the best embryo to transfer. And that can be done several different ways, and choosing the right embryo to transfer again becomes very, very important when you're trying to optimize your implantation rates. So this is how you troubleshoot and you go to find where your problems lie. As far as the gametes are concerned, it's the chromosomal abnormalities. And the chromosomal abnormalities in the gametes accounts for 30 to 40% of implantation failures. Maternal age over 40, 40% of the oocytes have aneuploidies. So it doesn't matter what you do in the laboratory. It is not even the fact that you are ending up getting 1 or 2 eggs with out of them. It is the normality of the oocytes that you're getting. When the majority of them are going to have aneuploidy, the gametes have aneuploidy, the women don't have aneuploidy, the gametes have aneuploidy, which means that the reduction division has not happened properly, and you have excess or lack of one chromosome or another leading to aneuploidy. And the commonest chromosome for some reason seems to be chromosome 16 that has this. So good quality embryos, what looks normal under the microscope can also be abnormal chromosomally, and that's the main lesson that we have to take. The sperms that look normal under the sperm can be abnormal. The chromosome, the gametes, the embryos that look normal under the microscope can also be abnormal. And how then do you find out? That's when procedures like PGD, PGS come into play. Fish technique is used for X, Y, 13, 18. Even if you use it for these 5 chromosomes, the aneuploidy rate that's picked up in embryos also is fairly high. And when you hit the age group of a woman who's between 40 and 47, a good 35 to 40% of the embryos will be abnormal, and there's nothing much you can do about it. And increased translocations, mosaics, deletions, chromosomal breakages in the centromere happen even in young women with high order recurrent implantation failure. So when you have something called recurrent implantation failure, these are the areas that you look at. Increased incidence of, and it's very difficult to diagnose these problems in a woman with the oocyte inside the abdomen, but it's easier to look at the gametes in a man. And we have to be aware of the fact that 50% of the success rate depends on the quality of the sperm as well. Increased incidence of sperm chromosomal problems and DNA fragmentation index can be another cause of failed implantation failure, and especially if it's recurrent. And this is something now that is giving us a lot of answer in recurrent implantation failures, recurrent unexplained infertilities as well, when you have a fragmented DNA, and there are only standardized tests which can pick it out, which is not some of the tests which are available called halosperm and all that. We look at very small numbers of sperms. They don't give you a meaningful result about how much of the sperm is abnormal. There is a test called SCSA, which gives you the percentage of sperms which have to be normal to create a normal pregnancy. So chromosomally abnormal embryos fail to implant despite a good morphology and a developmental rate. So you have to have gametes which are normal for you to start with to get a good implantation. And the next thing is, when the gamete is normal and you're looking at the embryo, another thing that you have to look at is the zona pellucida, which is like an eggshell. That's the shell outside the embryo, and it naturally hardens after fertilization. But however, in some cases there is an increased zona hardening, and that happens in vivo in aging gametes. Aging gametes, it can happen. In vitro conditions also can harden the zona pellucida. In vitro culture conditions, if they're not appropriate, that can also harden the zona pellucida, making it more difficult for that particular embryo to implant. So failure of the zona to rupture, it's like an eggshell, the shell has to open out and the embryo has to come out and implant. That failure of the zona to rupture can also cause an implantation failure. What can you do about it? There is a procedure called assisted hatching, where only 25% of the blastocysts hatch in vitro, the rest of them will not hatch in vitro, and you do not actually put in a hatched blastocyst. You usually put in a blastocyst which is not hatched. But there is a procedure called selective assisted hatching, which is often recommended for women who are over 38 years, or where you are finding under a microscope that the zona or the shell of the embryo is too thick at over 15 micrometers to improve the implantation rates. However, this procedure requires a lot of technical expertise on the part of your embryologist, and only then it can be done. And assisted hatching and ART, if you take it on the whole in published literature, there is insufficient evidence to determine any effect of assisted hatching on the take-home baby rate as such. And it's a multi-center trial. And what does a blastocyst culture offer? If a woman has a problem with implantation only, what you think is a cleavage stage embryo, day 3 you're putting the embryos back, it's the cell stage when you have 8 cells and it doesn't implant. Would culturing it for 2 more days outside improve the chances of this embryo implanting is the next question. And what that is called a blastocyst. By when you can have a growing blastocyst or day 5 or day 6, does that offer the woman a better chance for the implantation to happen? The advantages of blastocyst culture are you can select the embryos better. If you have even what looks like good quality embryos on day 3, your blastylation ratio in a good laboratory, in a lab that can grow the embryos to day 5. Not all of laboratory conditions are adequate enough for this blastocyst culture. Unless you have a very good laboratory, you should not even try this. And if you try this, your blastylation rates should be proven to be at least about 50 to 60%. But that is what you expect. Only half of your embryos will reach the day 5 stage in the laboratory. And that again tells you that these are the better embryos that grow up to day 5 outside. So there is a chance for an improved embryo selection because these are embryos that have survived up to day 5, and they are a little bit more likely to be chromosomally normal. And there is also an increased embryo-maternal synchronization, which is more physiological. Normally embryos don't get implanted in the endometrial cavity on day 3, which is when majority of embryos are being put back today. But that is not the actual synchronization that happens in a normal condition. In a normal pregnancy to happen, the embryo does not enter or get implanted on day 3. So when we are expecting it to get implanted on day 3, the synchronization is not quite physiological. So waiting for day 5 makes the synchronization more physiological, and you can expect an improved implantation rate of up to 40%, whereas with your cleavage stage embryos, it may be half of that. But what are the disadvantages? This is what I was talking about. Not all of your embryos are going to grow to a blastocyst, and suboptimal embryos can also grow sometimes better inside the uterus. So there is an argument saying that you putting it back in the uterine environment a little earlier might help the embryo, which may be suboptimal. And who's likely to benefit out of this blastocyst culture? Only if you have a patient with over 10 good quality embryos or on day 3, you can even go for a blastocyst culture. If somebody has 2 or 3 good embryos on day 3, you generally do not opt for a blastocyst culture, because by then none of them might grow and you may end up with no embryos for transfer. And patients who are at a higher risk for multiple pregnancy, you can go for a blastocyst culture in young women, donor egg recipients, women at high risk for pregnancy-induced medical problems where you do not want a multiple pregnancy, maybe candidates for blastocyst culture. Failure to conceive in at least 2 previous cycles, implantation failure despite what you consider good embryos may be another reason for culturing up to blastocyst. Does co-culture help? Co-culture is culturing the embryos with some other human cells. These are called the helper cells. Would the helper cells make a difference for embryo morphology or the outcome? Most promising co-culture is culture the embryos along with endometrial cells, but majority of IVF units today do not have the needed facilities or experience to do this co-culture adequately, and if you do not have the expertise, it cannot be attempted. And choosing the right embryo is the next great thing. Choosing the right gamete is the first one, choosing the right embryo is the next big step, and the role of PGS comes into play. Because euploid embryos can be selected for transfer with improved implantation rates. These are chromosomally normal embryos. You make sure that the ploidy is normal for these embryos. But however, trials have failed to detect a better clinical outcome when PGS is performed. And current ongoing studies are using ARRAY-CGH, where all of the chromosomes are looked at, and the results are yet to be confirmed. As yet, it's not something that you recommend for everybody because it's a pretty expensive procedure. Second, you're interfering with an embryo, taking cells out of it and culturing it, and a lot of times some of the embryos do not survive the procedure as well. Choosing the right embryo, in the morning there was a talk about the current equipment, the newer equipments which are coming in, and one of the things that's been talked about in ART scenarios a lot, which other people may or may not have heard about, is something called an embryoscope. It's a time-lapse, non-invasive video imaging of the embryo growth. In other words, you put the gametes inside this contraption. It's an incubator, but the incubator takes pictures. In very simplified terms, you have an ongoing video recording of what happens to the embryo inside the incubator, which we never used to do. You had to take the embryo out of the incubator, look at it under a microscope, and all of this was disturbing the embryo. So this is where the pictures are taken sequentially, and you can look at what happens to the embryo in that 48 hours or 3 days that you leave it inside the incubator, and then choose which one is growing at the right stage, at the right time, and then choose the right embryo for transfer. For a couple of years, this was thought to be the piece of equipment which will improve the implantation rates very significantly, because you could judge which embryo was the better embryo even without resorting to your embryologist. It's pre-recorded and and it's, you do that kind of a thing. But however, now it's used all over the world in many institutions now, but still it hasn't really proven that using this technology actually improves either pregnancy rates or implantation rates. And another ongoing investigation is in the choosing right embryo is in the realm of embryonic secretomes. These may be newer technologies which are having newer names which are coming out into the reproductive medicine arena. Viable embryos identified by the protein secreted into the culture media. In other words, you don't only look at the embryo, you look at the culture media around the embryo, and you take the spent IVF media, whichever IVF media, culture media that the embryo is growing in, you take the culture media and analyze the culture media to assess the embryo. And there is a distinct protein signature at each 24-hour developmental stage in the culture media. And there are proteins in the culture media which are implicated in implantation. Certain changes have to happen in the embryo which is reflected in the culture media that it's growing in, and you can analyze the culture media and say which embryo has a better likelihood of implanting. These are called the omes and the omics. This is the technology terms which are used now. There is something called genomics, transcriptomics, proteomics, and metabolomics. And these are the current technologies. The profiles in the culture media are used. Non-invasive assessment of endometrial receptivity is again used for a transvaginal ultrasound, is what all of us are familiar with. Potential ultrasound markers to assess endometrial receptivity, we've heard about them yesterday, 3D imaging and the volumes. And the embryo transfer timing, is your timing right? It's not just the days. There is something called an implantation window that seems to change from woman to woman. And there is a current technology intensive test which looks at the genomics that happen in the endometrium. It's called an endometrial receptivity array, which tells you what day that particular woman's endometrium is ready for the embryo to be replaced in. Endometrial injury, you again heard about it, the scratch of the endometrium prior to transfer, the techniques of embryo transfer, and which is all very, very important steps in that. Thrombophilia and immunological factors which can make a difference for the implantation embryo in endometrial interaction, where things like low molecular weight heparin. But adjuvant pharmaceutical therapies, you can look at the whole thing there, the spectrum of it from aspirin to 1 minute. I'll take a couple minutes because I thought it was a longer talk. And, that a whole host of things have been used, and has been no significant beneficial effect has been shown with any of them, so there is no point in blindly using it. Ovarian stimulation can change. There are people who resort to mild ovarian stimulation now, which makes the gametes better. Hydrosalpinges need to be excised. Endometriosis needs to be dealt with. Intrauterine problems need to be dealt with as well for implantation to occur beneficial. So these are the areas that we have to look at correcting. And the conclusions would be implantation success depends upon a multitude of factors, all or most of which must be right for implantation to occur. Meticulous attention to detail at all stages of treatment process is vital. We are only just beginning to understand the process of embryo-endometrial interaction, which is required for implantation to occur. And I think we have to look at all of these things for the implantation to occur successfully. Thank you.